For more than 3 decades, the federal government has operated a program designed to give certain healthcare providers the option to buy discounted prescription drugs while still getting a full reimbursement from Medicare and other health insurance plans, with the intention that the savings would be invested into care. Critics of the program, though, argue that the covered entities like hospitals and clinics have essentially pocketed the money as part of an opaque process, while defenders say the discounts make it possible to deliver care for low-income and medically underserved patients who are often treated at a financial loss to the institutions. For more on this dynamic, we're joined in the Capitol Press Room by Bill Smith, a former vice president with the drug company Pfizer and now a senior fellow at the Pioneer Institute, a right-leaning think tank. So what's your take on how this discounted prescription drug program, known colloquially as the 340B, is being implemented? And while it was created by the federal government, are there opportunities for improvements at the state level?
I believe there are opportunities for improvement at the state level, but the program has exploded in growth. I mean, 340B sounds like a nerdy topic, but it is the second largest federal drug program after Medicare, and it's likely to surpass Medicare within a couple years. It's twice as large as the 50-state Medicaid drug program. It started out as a small safety net program. There were only 9 pharmacies in the program in 2000. 96 hospitals. They only had about $1 billion in sales. Last year, there were 3,000 hospitals and 32,000 pharmacies participating in the program. The program has absolutely exploded. It's kind of easy to understand why. It's become a sort of a profit center for some hospitals. A hospital can buy a drug at 60% or 80% discount. If they resell it to Medicare or someone with commercial insurance, as you mentioned, they can pocket the spread. You know, like oncology drugs are particularly prominent in the 340B program because they're so expensive. A $100,000 oncology drug may be able to be purchased by a hospital for $25,000. And then they can bill Medicare or a commercial insurer $100,000, and they can pocket a $75,000 profit. This is how what generates the program. And this ability to kind of arbitrage the discounts is what I feel has made this program get off track. Hospitals have every reason to bring in fully insured patients and wealthier patients, not low-income patients. You know, if they bought that $25,000 oncology drug and they give it away for free to an uninsured or low-income person, guess what? They're out $25,000. They have every incentive to go out and bring in fully insured and wealthy people. And what we've seen is some hospitals have expanded into wealthier neighborhoods, and we've seen contract pharmacies placed in upper-income neighborhoods. So in New York, for example, 64% of the pharmacies, 340B pharmacies, contract pharmacies that contract with hospitals, 64% are in upper income neighborhoods, not in low income neighborhoods. So that tells you who they're going after. Now, that said, some hospitals and clinics are doing the right thing. For example, Cook County Hospital in Chicago gives away 11% of their operating revenue in charity care. And they're a $1.1 billion hospital in operating revenue. So they're giving away $100 million in charity care every year. That's an astonishing sum if you consider the national average for charity care for 340B hospitals is 2%. They're giving away 11%. I don't want to reform the program in a way that harms people that are doing the right thing, but the program does need reform.
And what kind of changes should then be made at the state level? Because it seems like cleaning this up might be Washington's responsibility, but at the state level, should there be more transparency or mandates about how money is spent and accounted for?
You know, it's not uncommon for states to require nonprofits to make certain financial filings. And that's what I believe should happen on the state level, some transparency. So hospitals need to tell the state exactly how much money they've taken in, how much have they pocketed from the 340B program, and exactly where did they spend it. Did they spend it on executive salaries, or did they spend it on charity care or free care for the uninsured?
But how would you know necessarily how dollars are being spent? Because it's not like someone takes in $1 from the cafeteria and says that's going here and the $1 from insurance is going here. How would you try to assign how money is being spent?
I know money is all fungible, but you could require hospitals, for example, to deposit all their 340B revenues in one account. and then you could audit that account for the expenditures. You could see exactly where they're spending the money. I think it's possible to have transparency that gives some idea whether a hospital is being a good actor or a bad actor.
And what would be the next step then? Because I have to imagine just knowing where the money is going isn't the end goal of a campaign like this.
Well, hospitals that are not giving a certain level of charity care should be required to do that. And also to get access to the 340B program, there should be a very firm understanding about how much a hospital is serving low-income patients. Right now, when the program first started, they had a pretty reliable application process. A hospital had to prove that 11.75% of their patient population was Medicaid. And that was thought to be a proxy for serving low-income communities. But the Affordable Care Act changed all that and gave hospitals a million ways to become 340B institutions. And I will tell you that Mass General Hospital, which is a Harvard hospital in downtown Boston, qualified for the 340B program as a rural hospital.
It's not necessarily the great outdoors over there.
No, I know where Mass General is. It's right, and it's a wonderful hospital, but should they have access to 340B discounts when they have a $200 million endowment through Harvard? I mean, I'm not sure they should.
Well, who would benefit from a change in the status quo? Who would potentially have maybe their pockets either enriched or have less taken from their pockets if, for example, those hospitals where you feel like the money is going toward executive pay and not going toward the care for low-income patients, who stands to benefit from changing this?
If they reform the program properly, low-income patients could benefit enormously. This is a huge safety net program. As I said, it's $81 billion in sales at discounted prices, and that's and the average discount is 60%. So right now there's about $164 billion in sales at list prices. That's a lot of safety net for low-income people. And hospitals are getting billions in profits through this program, and many of them, some of them are, but many of them are not, turning it around and giving out free care.
So this conversation, though, is not happening in a vacuum. We are hearing from healthcare providers of all sorts about how they're concerned about federal dollars flowing to their operations in the future, whether that's direct support or changes to Medicaid that are going to impact the populations they serve. So why make a change to this right now before we see how all these other variables shake out?
Well, Medicaid cuts are coming. And one way to deal with Medicaid cuts is to reform the 340B program so that more charity care is given out. Because a lot of people are going to fall through the cracks with these Medicaid cuts. So if 340B is providing 10 times the free care that it's providing currently, you're gonna mitigate the damage that's being done by the Medicaid cuts.
For those entities where I guess an argument can be made that they don't need the extra discount that they're getting from 340B, would you see that money essentially go back into the system or just not be made available? Because I feel like there are some players who would say, hey, if they don't need it, we could really use even more of it here at our facility.
Yes and no. I mean, what I'd like to see is the discounts, which are substantial, being passed on to patients. Right now, some federally qualified health centers, for example, are good actors in the program, and they give their patients discount cards. And at the pharmacy counter, they can access part of the 340B discount, which is sometimes substantial. There are drugs in the 340B program which are called penny drugs. The hospital buys it for a penny. Now, those discounts should be passed on to patients so they could pay a penny at the pharmacy counter. And many hospitals don't do that. I don't know of a single hospital that gives out discount cards to their patients.
And is that necessarily a bad thing? I mean, should we let the hospitals determine where this money is spent, or do you think, and it sounds like you think this, that the money and the best decisions about that money should be left up to the consumers?
Well, I think that the hospitals know which patients require free care. So to the extent that hospitals know that, hospitals should be making the decisions about who gets free care. Because when you check into a hospital, they evaluate your income and they determine whether you're a charity care case. And right now, they're not extending a lot of charity care to these patients, even though they know they're low income.
Coming back, though, to the idea that some of this is fungible and, might be hard to track, is it possible that in trying to impose accountability measures, we're not necessarily going to be able to accurately express and recognize the way that these providers, hospitals, community health centers are using this money to fund their operations so that they can continue to serve low-income populations? And if we can't capture all of the ways that they spend money to do these things, is it possible that we're going to have unintended consequences for these providers who are critical in terms of serving the medically underserved, Medicaid population, et cetera?
Yeah, that's a fair question. But again, I think it's solved by putting 340B revenues into a separate account and then monitoring and auditing the expenditures. So you can know if the hospital is giving $50,000 for a low-income patient to have a hip operation and is taking the money and paying the physician and paying the surgeon because it was too low income. That problem can be solved by software. You just code it a certain way and you know that it was charity care. And right now, they don't do that.
Well, we've been speaking with Bill Smith. He is a senior fellow at the Pioneer Institute, a right-leaning think tank. Bill, thank you so much for making the time. I really appreciate it.
Dave, thanks for having me.
Support for the Capitol Press Room is provided in part by the Lawsuit Reform Alliance of New York. Fraud and lawsuit abuse impact car insurance costs for New Yorkers. Reforms are being proposed to mitigate their impact. Information on these reforms is available at keepnewyorkaffordable.org.
Support for the Capitol Press Room comes from O'Donnell & Associates, a public affairs firm providing strategic guidance to businesses and nonprofits on navigating policy and regulatory issues. More information is available at o'donnellsolutions.com.